I'm Stephanie Kennedy, the Policy Director here at the Council. Today, I am delighted to welcome you to our webinar highlighting Medicaid and Reentry and exploring new policy advances to improve public health and public safety. If this is your first time joining a Council on Criminal Justice event, welcome. The Council was founded to advance understanding of the criminal justice policy choices facing the nation and build consensus for solutions that enhance safety and justice for all. We are a think tank and an invitational membership organization, and we are guided by the belief that a fair and effective justice system is vital to democracy and a core measure of our nation's well-being. That mission has driven our members and staff to take on some of the most pressing and most high-profile issues in our field: the impact of COVID-19 on our criminal justice system, reform of law enforcement policy and practice, violence in our communities, and racial disparities, just to name a few. Over the last year, we've partnered on the Health and Reentry Project to promote continuity of care between correctional and community settings, and to maximize the benefits of Medicaid policy change for public health and public safety. Today, we'll hear from our project director, Vicki Wicino, and leading experts on recent changes to Medicaid policy. We've planned plenty of time for questions and answers, so please submit your questions through the Q&A box at the bottom of your screen. If you're a member of the media, please identify your outlet. Also, just a reminder that today's event is on the record. I'd now like to introduce HARP's Executive Director, Vicki Wicino. Vicki served as the Deputy Administrator of the Centers for Medicare and Medicaid Services, or CMS, from 2015 to 2017. Under her leadership at CMS, the United States achieved the highest rates of insurance coverage in its history. Vicki, I turn things over to your capable hands.
Thank you, Stephanie, and thank you all for joining us. I'm really excited to be here with you today on behalf of the Health and Reentry Project. As Stephanie said, we created the Health and Reentry Project as a partnership with Waxman Strategies and the Council on Criminal Justice and myself to establish a cross-sector initiative specifically designed to improve the health of people who are returning to communities after leaving prison or jail. We've been working to advance stronger policy and practice at the intersection of the healthcare and criminal justice system by building bridges across stakeholders. And our goal is to improve the health, safety, and well-being of people and communities. Over the past year, we convened people with diverse perspectives on the health and criminal justice systems to discuss how to increase health and safety, specifically by changing Medicaid's role to better meet people's health needs at reentry. There will be links to the products of those convenings in the chat. And we're delighted that you've joined us here today to talk about the groundbreaking new policy guidance to states that the Centers for Medicare and Medicaid Services issued just last week. The guidance aims to promote greater continuity and access by allowing Medicaid, the insurer for people of low incomes, to cover some services in the time period just before someone's released from prison and jail. Why is this a big deal? Well, historically, federal laws prevented Medicaid from covering services provided in prisons and jails, except for hospital stays. In recent years, as states and jurisdictions have worked to connect people to services after release, they've increasingly identified their inability to reach into prisons and jails before release as a barrier that is preventing people from getting the health, mental health, and substance use services they need. Health outcomes in the immediate post-release period, including high rates of mortality, are widely recognized as being very poor. This new policy encourages states to amend Medicaid's inmate exclusion to provide pre-release services through Medicaid 1115 demonstration waivers, which are a long-standing tool to pilot new reforms. 15 states have already made proposals to the federal government, and CMS approved one state's proposal, California's, in January. Today's webinar aims to spotlight these new policies and what the field of organizations and people who carry them out can do to improve the health and well-being of people as they leave prison and jail. Now it's my privilege to introduce today's speakers, four people whose leadership I find inspiring, and I hope today you will too. Links to their full bios are in the chat, and I'll just tell you a little bit about some of their many accomplishments. Then I'll guide a conversation, and as Stephanie said, we'll reserve a few minutes at the end for your questions. Let's start with our federal leaders, and of course, we'll start with Dan Tsai. Dan serves as Deputy Administrator and Director of the Center for Medicaid and CHIP Services at CMS. He leads the center's work in addressing disparities in health equity and works hard to meet the needs of the many millions of people and families who rely on Medicaid and CHIP. Previously, Dan led landmark delivery system reforms in Massachusetts, where he served as the state's Medicaid director. Dan led the development of CMS's new guidance. Next, Amy Solomon, who's the Principal Deputy Assistant Attorney General of the Office of Justice Programs at the Department of Justice. She's been in that role since 2021 and leads the department's funding, research, and statistical priorities, including overseeing more than $5 billion in annual grants to support justice activities. She comes to this role with a long background in criminal justice policy and previous stints at DOJ, and previously served as Vice President of Criminal Justice at Arnold Ventures. Amy and DOJ are strong partners to other agencies, including CMS, and will play a key role in implementation of these new policies going forward. We're also excited to be joined today by two leaders in the fields of health and reentry. Both served on HARP's advisory committee. You can find the full list of our advisory committee members in the chat. I'm delighted to introduce Illinois Lieutenant Governor Julia Stratton. Her portfolio in Illinois includes leading the Justice, Equity, and Opportunity Initiative. She also chairs the Illinois Council on Women and Girls, the Governor's Rural Affairs Council, the Military Economic Council, and the Illinois River Coordinating Council. She has served in a variety of leadership roles, and all who know her know how committed she is to improving public safety and building stronger communities. And finally, Cleo Cumberbatch, who's Director of Strategic Partnerships at the Council on Criminal Justice. Cleo is a nationally recognized, formerly incarcerated advocate for criminal justice reform. He was pardoned by New York Governor Andrew Cuomo in 2014, went on to earn a master's degree in social work at the City of the University of New York, and while he was there, was awarded the Urban Justice Award for his work with underserved and marginalized communities. Thank you, all four of you, for joining us. Dan, let's start the conversation with you. In a nutshell, tell us what the new guidance does and why CMS issued it.
Thanks. Well, first, thanks for having me and for us and the group here in this discussion, and also to the community for having engaged for quite some time on this topic, including over the past year and a half with countless stakeholder listening sessions and things of that sort. And our team has done a lot of work with our DOJ colleagues and others around this. We are incredibly excited by the guidance and what it means for really expanding equitable care to a whole set of folks that really don't have it today for reasons that once you start to think from a common sense standpoint about outcomes and such, we're just excited. The guidance fundamentally outlines a federal perspective around what are some of the minimum requirements for a state to really take up the reentry opportunity within Medicaid for the justice-involved settings. And that includes things like reentry services, the availability of medication assisted treatment and other case management services. They're kind of a bare minimum, with many states wanting to go far above that. But it outlines kind of what that expectation is alongside some of the primary goals of what we're looking to achieve, which is both improved and strengthened health for folks in the carceral setting pre-release, but also making investments upstream and downstream in our healthcare delivery system and such that really help with reentry and some of the other issues and structural things that are leading to some of the health outcomes in incarceration we're seeing in the first place. The other piece that's really important about the guidance, and we would emphasize, is a lot of this is bringing a healthcare and a justice and carceral system together. And those two systems are very different. They have different ways of thinking about the world and even language at points. And the opportunity here is really to bring in some additional federal funding, but not just to have a nice budgetary impact, but to use the extra funding to really invest in a range of services, both in the carceral setting, upstream and downstream. And so the guidance outlines a range of goals and requirements for states to really use the enhanced funding to be expansive in nature in the carceral setting and upstream and downstream. So we're excited, and certainly that has a strong bearing around the more than a dozen states that we are now working with to work through their specific Section 1115 demonstrations around this opportunity.
Thanks, Dan. That's a great way to kick us off. As you said, the guidance establishes a floor of benefits. And I imagine that as you were developing the guidance, this was one of the key issues that you and the team focused on and thought about in the policy development. As you noted, some states have proposed to go far beyond this minimum already. And in fact, the one state that CMS has already approved, California, exceeds the floor. So tell us a little bit about why CMS landed on this set of services.
So the policy thing we always try to balance, right, is how to make sure that we are providing a path that really does something meaningful, that strengthens the carceral system and, again, healthcare and reentry around that, but also is accommodating enough to make sure that we can advance something in the broadest way possible across the country. And so we, in our stakeholder listening sessions, debated everything from require the entire way you do Medicaid outside of the carceral setting to be brought into the justice and carceral setting, all the way to don't set any minimums and kind of see what happens. Clearly, those two bookends are challenging for various reasons. And so through a lot of the stakeholder engagement and discussion and policy development with the teams, and frankly, looking at where the 15 states kind of were, we try to outline clear principles from a policy standpoint of what a minimum would be. Part of that actually includes, for example, ensuring that all folks leaving the carceral system would have literally have not just a script, but a 30-day supply of needed medication in hand in order to help assist with some of the transitions. I'm seeing that some folks are having trouble hearing me, so I'm moving my microphone closer, I suppose. I'm going to keep talking.
I can hear you, Dan.
Okay. And so that was really a lot of what we were trying to balance. So it establishes a bar that really accomplishes some of the core goals of the demonstration, whilst leaving some room for state level flexibility, recognizing there are going to be a lot of dynamics here across the country with different state, county, and local justice and carceral systems.
Great, thanks for that. As I get ready to turn to Amy here, I'll note that CMS did do an active stakeholder engagement over the course of years, and also that the policy guidance that they released stems from a provision of the bipartisan 2018 Support Act. Amy, let's turn to you now. Department of Justice is the nation's leader in advancing safety and justice. What is it about healthcare reentry that's important to you from DOJ's perspective?
Thanks, Vicki. First of all, let me say how wonderful it is to be part of this discussion. I want to thank you and the HART partners, and of course, Dan and everyone at CMS for your leadership in bringing us to this pivotal and truly game-changing moment. As you know, Vicki, I've been working on prisoner reentry issues for a very long time. And over the years, we've identified so many challenges to successful reintegration: employment, housing, education, and certainly health issues. And as you and Dan have raised, the incarcerated population has such a high disease burden with significantly higher rates of health issues than the general public. So this is so very important. We also know there's a huge treatment gap for those who are incarcerated. Far too few people who are in prison and jail get the treatment they need while they're incarcerated, and especially when they're released back to the community. And yet we know from the research that continuity of care is critical if we want to see both improved health and safety outcomes. And the stakes here are they're dire. People are coming out of correctional institutions. They have a much greater likelihood of being hospitalized and even dying from overdoses and other causes, especially in the days and weeks immediately following release. So Vicki, again, as you know, in a former stint at the Department of Justice, I worked with the Federal Interagency Reentry Council. You were, of course, at CMS at the time, and the Obama administration made some important progress in this space in the Medicaid arena, clarifying that states could suspend rather than terminate coverage in incarceration settings, and expanding access to Medicaid for those who are in certain halfway house settings. And this was breakthrough at the time and really an important stepping stone to what now feels like a watershed moment. And so I just want to acknowledge both your role here and the huge opportunity that Dan and his team have opened up with this new guidance. I also want to point out that the impact and the benefit here is not just for those who are incarcerated, but for the community at large. If we look just at 2021, there were more than 5 million people who were under some form of correctional supervision on any given day, either behind bars or in the community on probation and parole. And then millions of people are cycling in and out of jails each year. And when we extend out further to family members, the reach is even greater. So the potential for improving health outcomes here is really quite broad, particularly in Black and Brown communities that are already overrepresented in the justice system. So it just can't be overstated. Widening access to care, as this program does, would be a hugely important step in closing some serious and long-standing equity gaps. And just one more thought from a public safety perspective. When people return from prison and jail and haven't received the treatment they need, we know that they are less likely to succeed. And studies have even made some connections between increased Medicaid access and reductions in recidivism. And so from a public safety perspective too, it's just crucial that we support treatment when and where possible and create correctional environments that facilitate reentry in every way we can.
That's really well said, Amy. Thank you for that perspective. I want to pivot from what the new policy is to how to make it happen. Because as you both know, policy is only is just the paper it's printed on. It really takes action by a broad range of stakeholders to make the policy reality. And as Dan noted in his opening remarks, it's really unprecedented collaboration between the health and the criminal justice systems. So as we turn to that, Dan, when you think about the action that's required in the field, and as you put together the guidance, who are you hoping really took the guidance and run with it? And do you have one or two pieces of implementation counsel that you'd offer them?
Great question. I think in terms of who would, pay attention to the guidance and run with it, the good news is we have more than a dozen states that have already started running with it, that we feel like we are coming alongside to partner, and in a very bipartisan way. This is an issue that resonates all across the country, and we have quite a number of other states who have indicated a desire to go in this direction. The rest of that question actually is part of kind of what the 1 to 2 pieces of hopes. So much of making this work and really strengthening, again, both quality of care and outcomes in the carceral setting, as well as the reentry piece and back to the community, involves bringing 2 very different frameworks of how to operate together. And so that level of upfront partnership between a range of county, local, state, kind of correctional or law enforcement officials really working with the Medicaid agencies hand in hand, kind of bidirectionally, to bring a healthcare framework and a Medicaid framework into that setting, along with all the things that are requirements of Medicaid around what providers can do and the level of quality and program integrity and things of that sort. We recognize that is quite a sea change in how healthcare often operates within carceral settings today. We think that is really important. That really can only be accomplished by folks really sitting at the table together and thinking about how to best use the investment opportunities. The second piece I would say related to this is in so many states that we're talking to, I think folks really are thinking about how to leverage a range of community providers, both from a case management, a clinical standpoint, figuring out how to do so in an effective way to leverage that community capacity and also to link up successfully when folks leave the carceral setting, we think will be really, really important. And so to sum it up, I guess for this to work, it takes bringing very different parts of the healthcare and justice ecosystem together in a way that will actually work operationally on the ground. And we're excited. We think it'll take some time, but we're excited.
Thanks for that. Amy, Dan just noted that he's got state Medicaid programs lined up, looking for this new opportunity. Let's turn it to the carceral setting side. What should correctional leaders, policymakers who are interested in safety and justice, what roles should they play in implementation of these new policies?
Yeah, thanks, Vicki. Great question. I think I heard the answer in what Dan was saying, just taking it from a different lens. You know, the corrections leaders are obviously key to the effectiveness of any policy or process change. And their role is going to be so critical in allowing case managers and health providers inside their facilities to provide the pre-release services, which is a sea change in many places. And to get this kind of buy-in, it's going to take correctional leaders being at the table in discussions at every stage of planning and implementation, really from the get-go. And the CMS, the director letter really notes this at multiple points in the letter, which I think is going to be incredibly helpful in getting corrections partners to the table to think about both how to access and allow that kind of in reach of community providers inside, and also in the information sharing that's going to be really needed to make at that work. I would add that here at OJP, and particularly at our Bureau of Justice Assistance, we have started working, as Dan mentioned, with CMS colleagues to think about how we can help best support the corrections field in understanding and building capacity to implement the new waivers. And so we have a number of resources, including our Second Chance Act technical assistance and expertise from the National Reentry Resource Center, which we plan to leverage to help build that capacity and take advantage of lessons learned from early adopters along the way. We also have a number of grant programs that are designed to help establish connections between correction systems and support continuity of care in the community. These include our Second Chance grants, the COSUP, or Comprehensive Opioid Stimulant and Substance Use Program, which support a broader way, not only on the reentry side, but also prevention, harm reduction, treatment, and recovery support. And so, you know, we hope that making sure that those resources that are in play in different states and communities are going to be helpful to the cause here too. And the last note I want to add is that it's really helpful to have people with lived experience at the table when formulating these plans and policies. And we found from our own experience how valuable this is. We have 2 Second Chance Fellows who are now working with us at OJP, and they're talented experts, professionals who are also formerly incarcerated themselves, and they're serving as key advisors to our reentry portfolios. I think that will be helpful in this effort as well.
Well, it's really exciting to hear that you are already thinking about how to lead some of this work through, because I know what a vital role you play and DOJ plays in the field, and the fact that you and Dan have been talking about this is incredibly heartening, and I think that puts the policy already off to a great start. Dan and Amy, I'm going to come back to you in a second, but let's bring Lieutenant Governor Stratton and Khalil Cumberbatch from Council on Criminal Justice into the conversation. And I'm really eager to hear from both of them as leaders in the field. I think we're waiting for them to get on screen, but Lieutenant Governor Stratton, assuming that you can hear me, there you are, perfect, right on cue, thank you. As a state leader, I think your perspective is really important here. This guidance is aimed at states. And as a leader and someone who's worked at the state level in health and criminal justice, what stands out to you as most significant for states in this new policy? I think you might be muted.
Can you hear me?
Now I can hear you. Yes,
Okay.
thank you.
Thank you.
Thank you.
Yes, I apologize. I just wanted to first of all say thank you, Vicki, for moderating today's discussion and for these insightful questions. I also want to thank Daniel Sy and everyone at CMS, to Amy Solomon, and of course, Khalil Cumberbatch, and the entire team at the Health and Reentry Project for all of your commitment to these efforts. And what I would say is something that's most significant from my perspective is that this policy really just lays the groundwork for innovative and common sense approaches of addressing public safety, which, as we all know and just heard from the previous presenters, is inextricably linked with public health. Honestly, this news is also coming at an exciting time because I think about how here in Illinois, we are in the process of really pursuing ways to implement wraparound services through Medicaid for justice impacted individuals who are leaving incarceration. And that includes everything from case management to housing support services to employment assistance and so much more. But really our work is driven by seeing the whole person. You know, I think that's really what's exciting to me. The idea that we would see someone's whole being and all of the needs that they might have as they are exiting our system, so that they can successfully return to our communities. And I really believe that in so many ways, this policy speaks to that. You know, Amy said it earlier that this not only benefits the individual, but it benefits their families and entire communities. And I think that's what's really important, that this is not just about how each individual will hopefully have greater access. This is going to change the trajectory of their lives, their families' lives, and really help uplift communities that when we think about the population that is disproportionately incarcerated, we are seeing communities that have a great deal of need. And I'm excited that we're going to be able to address the health concerns and needs of individuals, but it's also going to uplift entire communities.
Thank you for that. And it's so appropriate that as you're talking, we all see the word justice behind you. Let's hone in on the community impact. If you're willing, what is it that you see as in this new policy as potentially having the greatest impact in community, and why?
Well, one of the things that we all know is that when people are returning to their communities after incarceration, that most are going to come back to their communities. I mean, if we think about the populations in our prison facilities, corrections facilities, most are going back to their communities. And that is whether or not they have the tools and the support that they need to succeed. So the first question is just thinking about, what do we want to happen? What do we want people to have so that they can thrive? And research has shown, of course, that their better health outcomes are directly linked to reduced recidivism. And that has an impact on the community, and it also has an impact on public safety, of course. So we need to make sure that the tools are available to foster health and wellness. I think this policy is also a recognition that safe communities are also healthy communities. And it really provides a roadmap to that. You know, I'm a restorative justice practitioner long before becoming lieutenant governor. And what we always say in the restorative justice world is that the wisdom is in the room. So I also want to lift up the importance of including those with lived experience, those who are justice impacted, being at the table to help guide and really be credible messengers, quite frankly, in communities around these issues. I really see how access to healthcare is at the center of everything, because we tell people as they are returning to their communities, you know, get a job and go to school and get housing and do all of these things so that they can re-enter into the community and continue to be contributing members of the community. But without your health, then it's hard to do any of those things. And so it's important to recognize that health is really at the center. and the ability to allow these access to services and healthcare is going to allow people to not only re-enter their communities, but to do the things that we are asking everyone to do to, again, contribute to their communities and live healthy, whole, and as thriving human beings.
Thank you for that. I think the statistics are that like 95% of people return to communities. So that's a lot of people coming back to your point. Khalil, let's bring you into the conversation. You work with criminal justice stakeholders across the country at the Council on Criminal Justice. What is it in this new guidance that you think is most important from the criminal justice stakeholder perspective in supporting reentry?
Yeah, thanks for the question, Vicky. Well, let me just start by saying I don't think we can overemphasize the importance of the moment that we're in. We are literally amid one of the most consequential federal policies that will potentially have a significant impact on reentry, as some of the other speakers have said, not only for the individuals, but their families, communities, and dare I say, public safety. So, with that said, I believe we'd also be remiss if we didn't acknowledge how much the new guidance itself would most advance successful reentry. The fact that we actually have this guidance in and of itself will change the field of reentry. Additionally, I mean, I thought it was vital that CMS laid out in the framework the minimal amount of services to be covered. I think that's going to be critical for criminal justice stakeholders. And those three are, well, at least in the summary, those three were case management services, which is going to be vital for someone who's trying to navigate the process of reentry, Medicaid assisted treatment, and a 30-day supply of prescribed medications, which in contrast to the current services that are offered is a tremendous jump and leap forward. And then lastly, I'll say that the guidance itself mentions in a number of places the utilization of community-based organizations, which I believe will be vital to the success of the program. CJ stakeholders all across the country, particularly those working in communities already providing reentry-based services, are going to be pivotal and key in making sure that individuals are able to benefit from this, and to also make sure that they're being navigated to the correct services that they need.
Thank you for that perspective. A few minutes ago, we heard from Amy the importance of, from the DOJ perspective, engaging people with lived experience of incarceration in the policy development. You bring to this work, and I have benefited from your expertise in this area personally, direct experience of incarceration. And I wonder, when you just bring that perspective to bear as someone who's gone through the process, who's helped others go through the process, what is most important in helping people succeed at reentry?
Yeah, well, I mean, the process of reentry can be very daunting, not only for an individual, but for also service providers, especially for people who have served lengthy sentences. To that point, misinformation and a lack of current and accurate information, unfortunately, always jams up the cogs of reentry for, again, not only the individual, but for also the stakeholder and the service providers, such as parole, probation, community-based organizations, as we mentioned, and also medical providers. I saw this firsthand as an individual who was reentering, but also as a service provider, someone who was a case manager at a small community-based organization, helping to navigate people who were released from New York City's local jails. And the information that was available to us, again, as an individual and a service provider, wasn't always clear on what type of services we could provide, what would actually be covered by Medicaid. And the guidance wasn't always, unfortunately, readily accessible. So from that perspective, I think the need for consistently clear, timely, and easily accessible information, and in some cases, access to technical guidance will be pivotal to the success of the program.
That's really helpful perspective. And as you were saying that, I was remembering that when we did our stakeholder convening last year about reentry, the reentry service providers talked about having someone in front of them they were trying to help, and they had to go Google to see what services were available and what programs were available. That's how fragmented and difficult the system is to navigate. One last question for each of you before we bring Dan and Amy back into the conversation. I think none of us think that these changes are going to happen overnight or easily. It's really going to require concerted effort. From each of you, I'd love to hear just like, what's the biggest challenge that you anticipate that you would really encourage the field to tackle?
Well, let me just jump in and say that number one, the fact that there's not across the board belief that healthcare is a right and not a privilege, I would say is a challenge. We need to make sure that, it's a challenge when people don't understand how important healthcare is. But and aside to that, I will just say that we need a robust infrastructure to help meet the needs and to address decades of policies and procedures that, quite frankly, contributed to poor health outcomes, and building that infrastructure to implement services equitably, share the information like Khalil spoke about in a real accessible manner. To build that kind of infrastructure, it takes time, it takes real intention, and it takes resources. And I just finally just want to say, and this is something that I think about a lot, and that is healthcare literacy, which is so crucial here. When you have been in a system for an extended period of time, and even when I think about just for any person, the idea of how technology is used in healthcare now, and what does it mean to have a primary care physician, or all of the other language that might not be completely accessible as well. I think it's important to make sure that people have the support to navigate this system. We've made some incredible strides. We're on our way, but we're all going to play a role in helping us to make sure that the intended impact happens.
Yeah, and I'll just say the absence of routine record and information sharing between correctional facilities and organizations on the outside cannot be understated. In many jurisdictions, there are antiquated record keeping, including things like paper files, and making continuity of care in those circumstances is especially difficult. And not only that, but also when you talk about differing data privacy rules across the healthcare and justice systems, it only complicates things even further. I think that once states receive a waiver, they have to prioritize the collaboration among an already kind of existing patchwork of systems and service providers involved in the prison to community transition. And that means supplementing not only federal Medicaid dollars, but also creating infrastructure for cross-system communication, step that was also named critical by the broad range of stakeholders that were convened in the Health and Reentry project. And lastly, I'll say, and I know that Amy and Lieutenant Governor Stratton mentioned this, but it's, another priority is hiring and training more case managers that include people who have navigated the same process in which they're trying to help people navigate.
And that reminds me, Khalil, that one of the areas that the guidance particularly calls out is the role that people with direct experience can play in service provision, including as community health workers. And in fact, that was a key element of the California waiver approval. Amy and Dan, I'd love to bring you back into the conversation. I know we're a little bit tight on time, so I'm going to ask you each one final question and ask you to address it briefly, and then we're going to turn to some of the great questions that are coming up in the Q&A. So let's fast forward. It's April 27th, 2033. So 10 years from now, what do you want to be able to say we accomplished in this policy? What was its impact? And what was the one key thing that it took to get us there? Dan, can I start with you?
Sure. I think 10 years from now sounds like a long time. Around 2033. I think a preponderance of states across a preponderance of CJ settings have care such that there is not a disparity between the way we think about the quality, access, and availability of care in the carceral settings with what one receives outside of the carceral settings, and that we are able to successfully connect people to mental health, physical health, health-related social needs services, so that folks can successfully re-enter the community, but also really advance on their healthcare goals. So that would be great.
Fantastic. Amy?
Well, I like that answer a lot. I'll just raise it one and say that I would hope that I would expect that we actually have a better standard of both health and safety for people who are inside and for people in the community. And I know that's a lot to expect, but I really think that this policy opening is a breakthrough and that has that much potential. And you asked about what's one thing it might take. I do think a key here is going to be being successful about the in-reach side, and the waiver structure should incentivize that. So not only can treatment regimens get started while people are still incarcerated, but also so relationships can be built between people who are incarcerated and healthcare providers in the community. This has been shown to increase the odds of healthcare follow-up in the community. And it's so important. So to me, that's going to be a big key here. And I just want to add that I think the reinvestment requirement that CMS built in is brilliant and could have a really positive upstream effect. So kudos to Dan and team on that.
Lieutenant Governor Stratton, where do you want to see us in 10 years and what will it take to get there?
Well, I think in 10 years, I want to see safer communities. And I want to see the kind of continuum of care where we are providing, we're looking at this and seeing how important it is to provide care in community first, so that we not only have a focus on reentry, but we have a focus on no entry, because people are getting what they need in community. And those who do end up in our corrections facilities are getting the kind of care that upon exiting that they can continue on. And that's going to require, as I want to reference what Khalil said, he's absolutely right. The technology that can help us to share information between healthcare systems and correction systems, that's going to be important to get us there. But to me, the goal is always, how can we have more no entry than just re-entry?
And Cleo, what would you add to this?
Yeah, I would just say, in addition to the points that myself and other speakers mentioned earlier about the importance of cross collaboration with medical and correctional settings, as well as community-based organizations, which in and of themselves are monumental. I would also add the importance of humanizing the individuals that we're talking about, particularly individuals who will be returning from prisons. And while many people in this country are becoming more and more educated and aware of the nature of prisons and jails and the process of reentry, many more need to understand that this is an important investment up front that will have benefits, again, not only for the individual, but for their families, communities, and public safety.
Great. We have a lot of great questions in the chat. As you would expect, that given that this guidance is very new, a lot of them are asking some specific questions on the guidance. So Dan, many of these will be for you, but I'll invite all of the panelists to jump in on issues that they would like to offer some context on. So Dan, there's interest in the chat on medication-assisted treatment, no surprise. And I think people are eager to hear a little bit more about what the guidance will do to advance both MAT and mental health services. Could you speak to that?
Both those are really critical. I think the guidance is clear that at a bare minimum, we are looking for, in order to approve the 1115, that states in their carceral settings would provide access to medication-assisted treatment. We even call out a strong desire to really think about all three forms of it, although there are some complications across the different modalities and such. But that is a really important piece. We also very much call out a strong encouragement for folks to consider the broadest sense of mental health services, treatment delivery, not just connecting folks upon reentry, but within the carceral setting, alongside a range of physical healthcare and other screenings and such that we also strongly encourage, everything from Hep C to other things of that sort. So those are all things that we really want to call states' attention to based on a lot of the feedback and engagement from folks with lived experience and our advocates. But we did try to make sure we were very clear about where the minimum standard would be.
Great, helpful, really helpful to hear. And if anyone else wants to jump in on that, just please raise your hand. Dan, also getting questions about whether the policy applies both in states that have expanded Medicaid and in states that have not yet expanded Medicaid.
So obviously things are a little bit more complicated in the states that have not expanded Medicaid. It's why we, as an administration, continue to hope and encourage and say we're open for business for any state that will even remotely want to consider Medicaid expansion. But that coverage gap that we've highlighted in the broader population, certainly it makes every element of this a much more complicated, not only when you think about reentry, but just what the state's eligibility criteria for Medicaid are. So I think it's a great point to call out. I think it's part of the broader push for why we think expanding Medicaid across the country is so important.
So one of our audience members is sounding a little bit of a note of skepticism on some of this, and the context in which they ask the question is concern that prisons are currently a punitive system, and that this guidance is trying to achieve a system that is not punitive, that is helpful. And they're particularly wondering whether it is realistic to expect prisons and jails to enroll people in Medicaid. I believe, Dan, there's some specific policies in your guidance around enrollment and application. So I'll ask you to speak to that, and then just maybe open it up to the panel to talk about this. The question about, is this, are prisons such a punitive place that we can't successfully execute health changes in them?
It's a great question. I would love to hear what the other panelists have to say about it. I would clarify, no, it's a great question that was raised precisely because of that. The guidance requires that states not disenroll individuals upon Medicaid eligible individuals upon entry into the carceral setting, but to rather either suspend the benefits or have a process that is at least as favorable to the enrollee, to the individual as that. Enrolling someone upon release or even it is a challenging process. I remember my former life working with some of the sheriffs and manual paper and Excel files being exchanged to try to figure out how to have coverage for folks when folks were released. And so we really made a point of saying all the stuff we talked about the healthcare elements and health-related social needs, that only works if you maintain and have coverage. And so that's why we put that in as another part of kind of the minimum standard for what each of the states would need to come in with.
I would just make the point that a lot of corrections directors, wardens, et cetera, they know that their institutions benefit when people who are incarcerated are in programs. It's a good use of their time, discipline. There are less disciplinary issues. It helps create a better culture. So aside from actually wanting all of the positive health benefits, which I do believe that many correction leaders would want, I think the benefits of having people engaged in services, in this case health services, is really positive, even for the climate on the inside. And I think we have one place to look that is a good example, and that is Pell restoration. Corrections leaders were behind Pell restoration, which would also have a lot of logistical complications of getting college classes on the inside and then continued when people got out. But they were for it, both for all of the right reasons, and it's good for the correctional climate and for individuals. So I hope we'd see that here as well.
Yeah, and I like Amy's, I think that's a great analogy, talking about the restoration of Pell. And I think that, when you talk about a punitive, system, for those who are working to be more restorative and have a restorative or transformative justice approach, the focus is on how do we repair harm. And, but that's just one aspect of it. There's also an accountability piece to it. And so the ability to have policies that really are going to repair harm from decades of policies that caused harm, I think it's important. And it's important to make sure that those, both on the inside, those that are justice impacted, are able to include their voices who have said, this is something that we want. We want to be healthier. We deserve to be healthier. And we deserve access to healthcare that will help us so that when we return to our communities, we can be successful and thrive. But I also think the accountability piece is important of how do we look at those systems and make sure that we are asking them to implement this in the right way and challenging and tracking and looking at metrics. All of that's going to be important to make sure that these types of policies are successful as well.
Yeah, and I would add that I think this is where the introduction of case managers is going to be vital. I mean, we're talking about case management services that not only happen on the outside, but ideally would begin happening on the inside. I would hope that those individuals aren't always going to be correctional staff. I would hope that they would give access, that correctional settings would give access to particularly community-based organizations who can train individuals, ideally individuals who have lived through that experience, to go on the inside and sit down with individuals getting ready to reenter and have conversations with them. I think that it is a fair level of skepticism to worry that correctional settings in and of themselves have the ability to make this process seamless, which is why, again, I think the importance of case management and by extension, community-based organizations are going to be pivotal.
Dan, we have two questions that both relate to the end of the public health emergency. As people in the audience probably know, people who are enrolled in Medicaid coverage have been able to stay on Medicaid during the course of the pandemic in order to help them get the health care that they needed. That requirement is now phasing down. I know Dan and his team spend a lot of time on this issue. So Dan, the first question is, how does that unwinding and the potential loss of coverage that comes with it interact with this new policy?
So I think just as a broader point, as you noted, Vicki, I think we, not only within the Medicaid team, but other parts of CMS and the federal government, with states, with others, preparing for Medicaid renewals and redeterminations has been the policy and operational priority from an immediacy standpoint for the past year and a half. We could talk a lot more about that, but we are hopeful and urging and partnering with pretty much everyone that will be willing to partner to try to make sure that people stay covered. Medicaid, Marketplace, Medicare, employer-sponsored coverage. For a range of the states who are proposing implementing this demonstration opportunity, that timing kind of intersects in different ways, right, with renewal timeframes. I think a lot of this will end up being a little bit state specific. And so I think, as specific questions come up, it'd be helpful to understand what those are and to see what we can do to help states, help carceral providers on this.
The second question in the PHE goes to exactly this situation, Dan, where states and you have been working day and night to try to make sure that the unwinding goes as smoothly as we can and people have health coverage. I think one of our audience members is wondering, how do I get on the radar screen of my state Medicaid agency when they are so occupied with addressing the need for people to maintain, for eligible people to maintain coverage as the PHE expires?
Is that a question for me?
It is. or anyone.
I mean, I think it is true that states are quite inundated because we are trying to help people focus on immediately preserving coverage throughout this. As I noted, the interest and commitment to what we're talking about here is really bipartisan, and the states that have come before us with proposals or are in the wings really span the entire gamut. And so hopefully that is some encouragement that this is really a nationwide piece of nationwide interest. And we would hope you'd be able to engage with your state Medicaid directors and teams. I know we have talked about this with the states collectively, and we'll continue to do that.
Great. Great. We've got just a couple of minutes here and so many great questions. We won't be able to get all of them. But a couple of questions on jails specifically. One question is for people who are incarcerated, who are in a pretrial status, does this policy apply to them? And then second and related, and these are both for you, Dan, I'm afraid, but I'll welcome Juliana, Khalil, and Amy jumping in with any perspective they'd like to offer. What to do about release dates? You know, some people are only in jail a few hours. It's really unpredictable. How does that new policy apply?
All great questions. And I've got parts of my team here and on who have been thinking about this, debating this, working with states. So I would say one important piece, the guidance really indicates a range between 30 to 90 days that states can choose for the reentry piece. The congressional piece in the Support Act described a 30-day opportunity. As we were working through with stakeholders, precisely because of the point of release dates moving around, to even do the things that we were asking for in that 30-day period. Sometimes you think you have 30 days and it's not 30 days. And so that was part of the justification for really being able to expand that window out to 90 days. On the pretrial piece, that definitely has come up many, many times. Again, the Support Act congressional piece was around a reentry piece. To the extent the pretrial piece fits within a 30 to 90 day window around that, that is included in the opportunity. But we, through this guidance, also linked to the congressional direction around this, really had to anchor things off of a number of days pre-release. And our hope is in many settings that would actually encompass in some of the pretrial detainees and such, but we know that will not be the case in every situation.
Got it. Thanks for that. Last quick question. We have a viewer with an interest in the juvenile justice system. Do these changes apply in a juvenile justice setting?
I'll take that again. So the guidance is clear that states can absolutely take this up within the juvenile justice system. In fact, and I would say there's quite a bit of congressional action that's already happened between the omnibus of 2023 and before around both how benefits already must be suspended versus terminated for youth in kind of going into the criminal justice system, as well as some additional things that Congress gave all of us direction on for juveniles and former foster youth relative to the carceral setting. So yes, this guidance applies, and there's some additional protections and things or unique pieces that Congress has outlined for juveniles and also former foster youth.
Yeah, I think that's a great point, because the changes in the omnibus, I think, are the first statutory changes that Congress has made to the inmate exclusion, and the juvenile reentry pieces will apply in all states. Now, of course, those changes don't take effect for another 2 years. So, Dan, I imagine, Amy, more policy work to come from both of you on that.
We have really good teams and really good.
A good and busy team, I take it. So that's all we have time for. Thank you, first of all, to our 4 speakers, Dan, Amy, Lieutenant Governor Stratton, Khalil. Thank you for lending your expertise and perspective to this conversation. Thank you to everyone who tuned in this afternoon and for your great questions. The Health and Reentry Project is looking forward to working with all of you to translate these new policy changes into a ground level reality that improves the lives of people and communities. You can stay in touch with us. We will put in the chat, if we haven't already, here it is, Alicia Lomax has just put it in. You can sign up for our email list and get additional information, including information on our forthcoming website and an issue brief that describes the California reentry waiver that will be out in just a few weeks. So if you sign up on the email list, we will get those to you. And my last task for this afternoon before I adjourn us all is a huge thanks to the HARP team, John Sawyer, Celicia Lomax, Margot Cronin-Furman, Abby Walsh, Stephanie Kennedy, and Zel Kalina. Thank you. And they are the ones who really made this webinar possible. I just showed up. Thank you all, and I look forward to working with you all going forward. Take care, everyone. Have a great afternoon.